Hi, this is Brian Kim. I want to share with you case number 106 in the best way to do cataract surgery series. This is a patient who has a 3+ dense lens with a little bit of weak zonules. So I'm going to show you double chop, cross chop mechanical fracturing techniques and how I'm able to reduce the usage of ultrasonic energy, which in my opinion provides safer surgery, less risk for complications, as well as clearer corneas after surgery. I have a lot more clear corneas, better visions, even post-op day 1 since I switched to this technique. So I'm using a cotton tip to steady the eye, and this is a corneal marker which will help me to center and size my rhexis. I'm using my diamond blade to make an incision, first on the right side and then the left side. And this incision is flat to the iris plane, parallel to the iris plane, which will allow me to make a nice corneal shelf and achieve a self-sealing incision. This is intracameral lidocaine and then some intracameral epinephrine. This is some dispersive viscoelastic to fill the chamber and to flatten the capsule. And this is a triplanar corneal incision. Using the cannula to hold the eye, I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, turn the eye towards me with the cannula, and then I enter. Push some more viscoelastic to flatten the capsule. And this is the rhexis forceps. Turn the teeth sideways, go in. And then I'm going to try to puncture the center. And as I try to do that, you can see there's quite a bit of give as I do this. So I go ahead and switch to the cystotome and puncture the center and pull downward. And then get a nice tear there. And then hopefully a little bit of a flap. Switch to the forceps again, grab the edge of the flap, go around circumferentially, again being mindful to try to size the rhexis to match the mark that I made previously. You want to grab every few clock hours, making sure you're not putting any tension on the incision, which will cause more viscoelastic egress, which would cause the rhexis to tear out more. So I finish off the rhexis, burp some viscoelastic out, and this will be the Capsulorhexis hydrodissection technique. I place a cannula out under the rhexis edge contra-incisionally, point it down, get a nice wave, decompress on the left side gently, and then point the tip down to the right, and you can see the lens begins to spin nicely there. Irrigate the surface of the eye, adjusting the exposure of the tip. Lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. And remove the surface epinuclear material. Placing the chopper under the rhexis edge, contra-incisionally, the phaco tip vertically sub-incisionally. Bringing both instruments together very carefully, which I'm able to engage the thickness of the lens and then fracture the lens in half. I'm separating the lens nicely there, making sure that there's good separation. I'm going to turn the lens 180 degrees here, and then I'm going to go underneath the lens again, and then I'm going to go around and try to separate it completely to make sure any adhesions posteriorly are separated. I place the chopper around the right heminucleus, pulling it centrally towards the phaco tip, crushing the lens against the phaco tip, and that is the cross chop now. So I have 3 separated pieces. Use some vacuum to lift that first quadrant up, and then using mechanical forces to crush the lens pieces, and then emulsifying the lens pieces. Placing the chopper underneath the second quadrant, pulling it centrally towards the phaco tip, crushing it and dividing it with the cross chop maneuver there, using some vacuum to pull that fragment up, using crushing forces to divide the lens piece between the instruments, and then emulsifying the lens pieces. I'm turning the second heminucleus in front of me, placing the chopper around the lens piece, placing the phaco tip deep in the bag, crushing and bisecting that heminucleus in half, placing the chopper around the third quadrant, pulling it centrally toward the phaco tip, and then crushing and dividing the lens. With that maneuver, you have to make sure that the phaco tip is deep enough that when you fracture it, it's going to fracture the entire girth of that fragment there. Removing some of those remnants from the second quadrant, just crushing it and then dividing the lens pieces. And this is the last quadrant, placing the chopper around the lens piece, pulling it centrally towards the phaco tip, dividing that lens piece completely, grabbing it and engaging it with some vacuum, and then crushing and dividing the lens piece into smaller pieces, and then I'll emulsify the lens pieces. So again, you can tell this is a pretty thick lens. It's not a cataract, but it's pretty dense. I mean, denser than the average cataract. But I'm very careful about completely crushing and bisecting each of the fragments between the instruments and then emulsifying the lens pieces. Now that the endonucleus is out, just remove the epinucleus, which tumbles out nicely. Take the chopper out, push BSS in, take the phaco tip out, and I go in with the I&E handpiece. But before I do that, I'm getting some ballooning. And so as I'm pushing fluid with the BSS cannula, I'm just use a scissor, and I'm just, taking down a little bit of conjunctiva at the incision so it minimizes the ballooning. So I go in with the I&E handpiece, start subincisionally sweeping side to side gently, and then peeling the cortex from anterior to posterior. Switch to polish mode and polishing and removing more cortical material that might be stuck into the fornix, and then polishing the anterior capsule of the lens epithelial cells. So when there's a little ballooning, it's not a big deal. Just go ahead and just do a little cut down, and that helps redirect that fluid. Instead of ballooning the conj, it'll just go above and away from the conjunctiva. So go ahead and pulse BSS into subincisional space. In this case, it was pretty clean there. Fill the capsular bag with cohesive viscoelastic, and then I'm going to sweep underneath the rhexis edge on the left side and then the right side. In these dense lenses, I always feel there's some level of zonulopathy, so I like to use 3-piece lenses in these cases. I'm going to use this blade, which will help widen the incision to accommodate the injector. So place the injector, turning the bevel to the left. The leading haptic comes out nice and flat, and it goes into the capsular bag. As the optic is delivered, I rotate my hand counterclockwise about 90 degrees, which allows the optic to come out correctly. Go ahead and use a multimeter to dial the trailing haptic into the bag. Go in with irrigation off, activate irrigation, and then I go underneath the lens, removing the viscoelastic from within the bag, repositing the lens back into the bag, and then I'll polish under the rhexis edge, and then remove all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient with a little bit of zonulopathy, not too bad. I use double chop, cross chop mechanical fracturing techniques. I'm able to completely fracture the lens in half using these maneuvers, making sure I crack the lens completely to get rid of any posterior adhesions that there might be. I'm using the chopper as a cutting instrument, and really the phaco tip is really more like a cutting board. It's just a fulcrum, a leverage place, whereas I'm pulling the chopper towards me and towards the lens material. The phaco tip is on the other side, so that it's basically like two walls that are crushing the material. And so it's two forces on either side crushing the lens, bisecting the lens in half. And again, it's very subtle, being able to position the instruments to crush the lens. You have to have that phaco tip deep enough that it completely fractures the lens completely, so there's no adhesions. And then just using mechanical forces to crush the lens pieces into smaller pieces. And again, you saw the CDE, it wasn't too high, and this patient had a nice clear cornea post-op and did well. So I hope this was helpful to you, and I thank you for your attention.